Good evening, everyone. Welcome to the March, it is March, right? 2023 Compassion Chat. My name is Susan Marshall. I am the author of Mom's Gone Missing, When a Parent's Changing Life Upends Yours, and the host of our monthly Compassion Chats. We meet the fourth Tuesday of every month at 6 p.m. Central Time right here on Zoom. Nobody's got to drive anywhere. Nobody's got to go anywhere. You can have a cocktail if you like. You can have a snack. Just kick back and relax with us. The sessions are recorded, so I would ask that as you join us, you mute yourself. We will open it up at the end of our chat for questions, for stories, for any comments that you would like to make. We are absolutely honored this evening to be joined by Art Walaszek.
Got it. Walaszek. No, you got it.
That. Just briefly, Art's got a long list of credentials, but Art is a board-certified geriatric psychiatrist. He's a professor of psychiatry at the University of Wisconsin School of Medicine and Public Health, vice chair for education and faculty development in the Department of Psychology, and a bunch of other list of credentials that you can find in the bio attached to the Compassion Chat. And also, Art, what's a good website to find your bio?
Actually, if you just Google my name, it'll go directly to the Department of Psychiatry website, and my bio's there. I work at the Wisconsin Alzheimer's Institute and Wisconsin Alzheimer's Disease Research Center, and so I've got bios there as well.
That's fantastic. Art's research focuses on public health approaches to improving care for people with dementia. So Art, as I think about this, I summarize it as you are a researcher, a teacher, an advocate, and a friend.
Well, those are very kind words. Thank you. And thanks very much for having me here.
Well, we are just, as I said, so honored to have you. Lots to dive into as we kind of preach at it a little bit. But we love to start our chats with getting a little bit about our guests. So if you could give us a bit of your background, and then what led you to do the work that you currently do?
Well, thank you. And thank you for this invitation. Thanks for having these compassion chats. It's an incredible service, and I'm honored to be part of it. Well, just personally, I'm from Chicago, grew up in the city, lived there for about 25 years or so, went to med school there, and then moved on to residency out in Seattle. And then back to Chicago briefly for fellowship. And then I've been in Madison, Wisconsin for 20 years on the faculty. The sort of the common denominator across all those experiences, and that led me to this work, is mentorship. So I had outstanding teachers, mentors, really starting certainly in undergrad, but in particular in medical school with respect to working with older adults, working with people suffering from dementia, and then especially in residency, where I was surrounded by terrific mentors and leaders and people who were quite inspirational about the value and the benefits of working with older adults. So I've had great mentorship and colleagues and friends along the way who have supported me in that. I've been a kind of teacher and clinician for most of those 20 years, including running our residency training program and teaching others about caring for older adults and so on. And then the research side has been a little more recent over the last 5 or so years, working with the Wisconsin Alzheimer's Institute and the Alzheimer's Disease Research Center, where again, I have terrific mentors and colleagues and resources. What kind of unifies all that is I'm really interested in how education can help improve the care of people living with dementia. So for example, I do a lot of work with primary care clinicians around addressing dementia, especially some of the emotional and psychological side of dementia. Our team at the Wisconsin Alzheimer's Institute has worked with dementia care professionals around the state of Wisconsin. We train folks on how to work with dementia caregivers, et cetera, et cetera. And sort of underneath all that are really educational models, the idea that we can teach people new skills and new knowledge, and that'll help improve the lives of people with dementia.
That's really phenomenal. And I think that's where all of this starts, right? because I can speak for myself, and I know many, many thousands of other caregivers. You're kind of dumped in the middle of a situation that you've maybe heard some things about, that you really didn't know much about, and you kind of figure it out as you go.
Yeah.
Which is not terribly graceful, if we can say it that way.
Sure.
Which is why we started these compassion chats, because when we're on our own and feel the responsibility to care for someone we love deeply and just don't know how, particularly with primary care physicians, who I'm so pleased to hear you say you're working with, because oftentimes they don't know much either, right? Please tell us that's better.
Oh, absolutely. I mean, I think first of all, there's just much better awareness about dementia, in particular Alzheimer's disease as a cause of dementia, among clinicians in general. I mean, there's better education in med school and residency about that. I think there's also greater appreciation for why it's important to make an accurate diagnosis and then link people to appropriate treatments and resources, and even other things like just helping people plan ahead. What are their wishes in terms of medical advance directives, or where they'd like to live in the future, and so on. So I think there's been a significant increase in a buy-in related to that, it's knowledge, it's also appreciation, but also skills. You need some skills to conduct an assessment of an older adult with memory complaints, knowing when to refer them for further evaluation, figuring out which tests you might want to order, et cetera, et cetera. And I mean, what I found in my work is there's great receptiveness among primary care clinicians to this. It's tough. It's a very hard job being a primary care clinician. You have to know a vast amount of stuff, and you have a wide range of patients. And so, only as a part of the population that you're caring for may be people with dementia or at risk of dementia. But I think folks recognize how important it is. And certainly with the aging of the population, there are just more folks out there with memory complaints and more older adults. So I love the work. I just met with a group of clinicians earlier today, and I've found people to be enthusiastic about this.
That's phenomenal. And I have to believe that they're appreciative of the information via research that you can help them learn and understand, because it is a specialty area, if you think about it, that they probably just have not been trained.
Yeah, absolutely.
So I want to talk specifically about depression and anxiety as it relates to elderly populations. We know it is an absolutely global issue. It has been done nothing but explode societally. How do you focus, Art, on the specific causes of perhaps anxiety and depression in aging loved ones?
Yeah, thank you so much. And so just some background ideas first, and then I'll dive into the details. So anxiety disorders are the most common mental health disorders in the US. Depression is fairly common as well, but not quite as common as the anxiety disorders. And so anxiety, I mean, we all experience anxiety. So that's like a normal part of life. If we didn't have anxiety, we would jump off cliffs and we would do other things that are just not wise for survival. So anxiety is normal to a huge extent and absolutely necessary for survival. But some folks have excessive anxiety that really gets in the way of being able to do things. So worrying constantly, being unable to turn off the worry, or having frequent panic attacks, or worry about things like germs and having to wash your hands over, et cetera, et cetera. There are lots of different flavors of anxiety disorders. What unites them is excessive worry that gets in the way then of day-to-day life and or causes significant distress. So those are anxiety disorders, as opposed to the normal day-to-day stresses and anxieties that we all experience. And generally anxiety is about like bad stuff that could happen, just sort of very simply put. Depression, we all feel sadness. So if we lose someone we love, that's normal. That's grief. That's not a pathological process. Or if something doesn't go our way that we were hoping for or expecting, sadness is normal. That's a regular human emotion. When the sadness becomes all encompassing or affects other areas like will to live or feeling hopeless or feeling terribly guilty or worthless, and it affects day-to-day function, that's a disorder. So there are different disorders, but for example, there's major depressive disorder. So that's how we think about the relationship between the normal emotions that we all experience and then the disorders. And older adults are not, are not immune to the disorders. And in fact, as the stressors go up, retirement, which could be good, but it could be stressful. You lose structure and relationships and so on. Losses in one's family, losses of one's health, those things can accumulate. And so people can develop anxiety disorders or depressive disorders. Or there are a lot of folks, unfortunately, who develop, most anxiety and depressive disorders arise like in the teens, 20s, maybe 30s. And then it sort of persists or recurs in later life. So they're kind of different flavors, folks who didn't have depressive or anxiety disorders earlier in life, and then as they age, those disorders can arise, or they've had them all along, and now the stressors of aging are contributing.
Well, and I'm so fascinated by that because as you were speaking, I'm hearing the causes for anxiety, depression for the elderly, and I'm like, sounds just like teenage years, right?
Well,
And so how, I guess, and I'm not sure this is a very astute question or one that you could answer, but how do you tell as a researcher and clinician when that line has been crossed in a way that is no longer recoverable in terms of this is now a full-blown disorder versus it's episodic? Mm-hmm. And we're still, functionally okay. Is there a line that you can discern?
Yeah, well, I think the good news about this is that depressive disorders and anxiety disorders are treatable. We have a wide range of conditions or treatments out there, and they're no less effective in older adults than in younger adults in general. There are some exceptions to that, but just in general, you give an older adult an antidepressant for depression, it's going to work just the same as for a younger adult. You have an older adult go to psychotherapy for anxiety, it's really going to have the same outcomes as younger adults. What's a little bit different, especially like on the medication side, is how well a person over 65 tolerates a medication. That's going to be different. So we think about like, what's the difference between risk and benefit? So the benefit is the same, but the risk kind of goes up a little bit. And so that window's a little bit narrower in older adults, especially things like falls. Any medication that gets into the brain can increase your risk of falls. And then pertinent to us, also talking about dementia, memory impairment. So you can have some memory side effects from these medications. So, so the bottom line is depression, anxiety, treatable, but it's a little bit trickier in terms of some of the side effects. So we want to identify folks who have a depressive or anxiety disorder and then get them into the right treatment, because odds are there might actually be a pretty good outcome for them.
So how do people and especially elderly people, come to the realization? I'm sure it is not something we rush to say, hey, I think I'm anxious, beyond normal, or I'm depressed. No, I'm good, I'm fine. How do people come to that?
Mm-hmm. Well, I think first, I'm sorry.
Just how do we, what's that trigger to go see the doc? Is it the caregiver?
I think first of all, one of the cool things I've seen in the last 20, 25 years is there has been a marked reduction in stigma around mental illness. And so people of all ages are much more willing and open to talk about depression, anxiety, substance use, ADHD, all different kinds of conditions. And it's been a pretty rapid shift. I think too, as we see, I think the baby boom generation, for example, just in general, not to overgeneralize, is more comfortable having these sorts of discussions. And their kids may be more who are very open to these discussions in general, may be more likely to kind of prod them along and say, hey, mom, hey, dad, I think you're depressed or anxious. It'd be, good for you to get some help. So family, I think, can be a big source of support. Hopefully not invalidation or no, it's just a phase, you'll get over it. I think we're, moving away from that towards recognition of it as, look, this is causing distress. It's a problem, and we can get you some help. So family is a big source of that. Medical care. So we are increasingly screening people for depression and anxiety. So it's not universal, but it's becoming more and more common. There'll be new recommendations coming out soon from the U.S. Preventative Services Task Force. They're the folks who make recommendations in the U.S. about how often people should be screened for different conditions, whether it's for colon cancer or for blood pressure or whatever. So their new guidelines they're in draft form right now will say that people over 65 should be screened for depression. Doesn't say how often, but we're going to see this more and more. So most people with depression and anxiety are actually going to get treated in primary care. So their treatment will begin and for most people will continue in primary care. There'll be a subset of folks then where the first and second line treatments aren't working, and then they may get passed on to someone like me, a psychiatrist or other specialist to help out.
So do you have a sense of what that screening process will look like, sound like? Yeah,
that's a great question. So basically these are like self-rated questionnaire kinds of things. So for example, there's something called the PHQ-9. The PHQ just stands for Patient Health Questionnaire. It's very simple. And 9 are the 9 symptoms of depression in the condition called major depressive disorder. And so that turns into a score. And if the score is above a certain cutoff, then it doesn't mean the person necessarily has depression, but it means, okay, we should pay attention to this and do a little more assessment. So these have become increasingly common. In my clinic, most patients will do one of these PHQ-9s before every visit. There's a similar one for anxiety called the GAD-7, and there are others. It doesn't have to be these, but they're all the same idea. Basically, you fill out a piece of paper or online, you do a questionnaire that runs through a set of questions. It turns into a score, which then might suggest that the person has depression or anxiety.
So I gotta ask, Art, what types of questions are people
sure. Yeah. Well, the depression questions are sort of in different clusters. So there are physical symptoms of depression, changes in sleep, changes in appetite, either up or down, changes in energy, down. So those are kind of the physical symptoms of depression. They're the more kind of cognitive symptoms of depression. A lot of depressed people have difficulty making decisions, for example. Their attention span may not be so good. Then there are the more psychological symptoms of depression. So those are things like low mood, feeling sad, losing interest in activities. So that's like a classic depression symptom, that people don't get joy or pleasure out of things that they used to. Feeling guilty, feeling hopeless, feeling helpless, feeling worthless. And then the big one, the one we worry about especially, is thoughts of death, feeling that a person would be better off dead, or they want to harm themselves. So to us, that's an emergency. That's like, if you have chest pain, like you got to go to the ER or call 911. And so similarly, if folks are having thoughts of death, now there's the new 988 number that's available nationally. So that's kind of easy access, dial 988 if you or a loved one are having any suicidal thoughts.
Well, and this is one notion and major red flag. I'm glad you brought that up, because it's one that in the work that I've done over the years and just many, many conversations with caregivers, people will say that and then say, I didn't mean that. I didn't really mean that. So there's always this discernment, right? Is this real? Yeah. Is it attention seeking? Is it so let's focus now just on chatting with caregivers who are having to make sometimes these determinations in family situations that are often full of discord and disagreement, and you keep your opinion to yourself and I'm fine and all. How do you help caregivers sort through all of that?
Such a great question. And so let me build a case for why it's important for caregivers to pay serious attention to thoughts of death, or statements that I wish I go to bed tonight and not wake up, or if I just had a heart attack and died, that'd be okay. So older adults, in particular men over 65, are at much higher risk of dying by suicide than younger adults. So that may come as a little bit of a surprise to some, but if you look at a graph, like especially for men, like things, there's a big jump in suicide risk in the teens and 20s, kind of levels off. There's another jump in like the 50s. We don't kind of fully understand what that's about. And then after 65, it just takes off. And if you look at like men over 85, they're at 4 times higher risk of dying by suicide than the general population.
Wow.
For women, it peaks in the 50s and goes down, but never goes to 0 in terms of risk. And so both older men and women are at risk of suicide. So that's pillar number 1 of my argument. Pillar number 2, most people over 65 who die by suicide were depressed in the period leading up, clinically depressed. It's like 90% of people who die by suicide. We can go back, we can do something called a psychological autopsy, where we go back and try to piece together what was going on in this person's life. So 90% of folks were suffering from a clinical depression. Depression is treatable. So that means we can actually save people's lives. And this has been demonstrated. So there are all kinds of interventions, whether it's antidepressants or teaching primary care docs or a brief course of psychotherapy. All these things have been shown to have an impact on suicidal thinking. So you could save your loved one's life by bringing this up as an issue. And it is really tough. I mean, even for me as a clinician practiced for 20 years to say, I don't know, what is the risk? What's the real risk here? And so it'd be especially hard for a caregiver to figure that out. So I'd recommend for caregivers have a very low threshold for contacting, primary care doc or 988 if it's more acute. Let the experts kind of sort out, is this, what is the risk associated with this statement?
That is fantastic. And I'm sitting here listening to you thinking, you know what, we've got to multiply this chat 1 billion times and get it out, because these are the kinds of questions that caregivers struggle with.
Yeah, absolutely.
When should I not? How much do I push and then back off? All of those kinds of things. Are there mistakes, Art, that you have seen caregivers make with all good intentions, trying to get elderly loved ones the kind of help that they need?
Yeah, it's, I'm stumbling a little bit because I'm not a huge fan of the word mistake, because I think people, as you said, they're trying their hardest. And, most of us were not really built to be caregivers, especially caregivers of folks with dementia. It's incredibly difficult.
And I get a big amen on that one.
And it's a 24/7 job and so on and so forth. So I think, the vast majority of folks are putting their best foot forward in trying to help out. So I think the things that caregivers could do could include, 1, learn more about the caregiving process, things like this, watch this video, or go to, look at other resources. There's lots of great web-based resources. For example, the National Institute on Aging has spectacular online resources for people with dementia, for older adults in general, for caregivers, about depression, about anxiety, about a wide variety of topics. So great online resources. There are great support groups out there of all sorts, and those can be educational, but also forms of emotional support. So 1, learn more if you can, if you have time, if you aren't completely burnt out from the caregiving process. And 2, seek help. Go out and whether it's through support groups or online or primary care, or in Wisconsin, we have this wonderful system of aging and disability resource centers, and many of them employ dementia care specialists. Or there are all these great social services folks out there who can help. Another way that caregivers, I think, can improve their effectiveness is to care for themselves. So it's that whole adage of, on the plane, put your mask on before you assist somebody else. Like if you don't have oxygen, you can't help other people. And similarly, if you're exhausted, if you're drinking too much, if you're not tending to your health care, and I appreciate it's difficult when you're very busy as a caregiver to do all those things. But if you're not doing self-care, it ain't going to work out. And especially like a lot of these conditions, these are marathons, not sprints. So it's can be many years of being a caregiver. And so having a routine built around at least a little bit of self-care, some respite, maybe someone else can be with your loved one for a bit while you go for a swim or have lunch with a friend, or, do something that is kind of helps restore. In that vein, sleep is really critical, and it's tough. A lot of caregiving issues arise at very inopportune times, like 2 a.m. when you're trying to get sleep. So it is tough, but whenever one can get some sleep, that's really essential. And sleep is so critical for our physical health, for our emotional health, for our own cognitive health as well. So to the extent possible, good healthy habits around exercise, diet, sleep, avoiding drugs and alcohol, and other self-care kinds of things are going to be essential for a caregiver.
It strikes a nerve with me personally, and I joke about it. It's not funny, but I have given talks with the title Chardonnay and Cheetos, How I Coped. Right. And that's a wonderful, so what I've told people, and I'm really interested in chatting with you about this, Art, as a clinician and a researcher, we have coping skills, right, or coping mechanisms that we really are wise not to beat ourselves up over. Mm-hmm. However, to recognize when that coping is becoming a crutch, mm-hmm. and now becoming part of this downward spiral of fatigue, mm-hmm. and sense of inadequacy, and I just can't do anything right, and siblings are yelling at me, pour me another glass of Chardonnay and give me another bowl of Cheeto. Right? How can you, so talk to us as a researcher of psychiatry and someone who has, I'm sure, seen a healthy individual kind of get caught in that emotional and psychological quicksand. Sure. How do you put the brakes on and say, you know what, whoa, time out, this is bad.
What a terrific question. Thank you. I love the word coping, and sort of we all have various coping mechanisms. So here's a little terminology around that. There's different kinds of coping mechanisms, and just very broadly, there are avoidant coping mechanisms, and there are kind of more adaptive coping mechanisms. So the avoidant things are, it's understandable. You're faced with a stressful situation. It'd be nice to escape from that, right? So if a bear walks in the room, having a conversation with the bear is probably not a great idea. You want to get out of there. So, avoid that, escape that situation, avoid that situation. So there's certainly a place and a time for avoidance as a way of addressing the situation. But most of the time, when it's not bear attacks, it's not a helpful mechanism, because the problem is still going to be there, and you're not necessarily in any better position after having avoided the stressful situation. So, drinking can be a way of doing that. You get an hour of respite, your mind sort of settles down a little bit, you can relax, watch a little TV, and there's nothing in principle wrong with that, but if that is one's primary coping mechanism, that's not going to work in the long run, because again, you're not really addressing the issue at hand. So more adaptive coping mechanisms may relate to actually some of the stuff I mentioned earlier, exercise. So exercise, there's a little bit of avoidance in that you're leaving the situation. On the other hand, you're coming back stronger, right? So like you feel better. There's a little rush of endorphins after the exercise. You feel good about yourself. You've accomplished something. So you've now come back in a slightly better position. or you attend a support group, or you have lunch with a dear friend. Those are things that are going to give you some strength, some purpose, some new ideas that you'll be able to come back better and face the stressful situation. So, the coping mechanisms aren't good or bad per se. They're just going to vary in terms of how helpful they are for the situation.
And that's really a helpful kind of framework to say, will I come back to this stronger, or will I have depleted myself in whatever measure, because I still have to deal with this, right?
Exactly.
What's the story that you would craft for a caregiver who is burned out, who is starting to feel hopeless, who is intellectually understands the stuff you're saying and just flat out can't find the energy to do it?
It's a very tough position to be in. And, I would wonder for a caregiver like that, are they depressed? Are they anxious? Are there things that are, getting in the way of getting the help they need? So I think this is where relationships are really important, turning to whether it's a sibling or adult kids or friends or the church or a, primary care doctor or whatever it might be, turning to those folks to get some additional help and respite. Because it's, once you've sort of dug yourself into that hole, it can be a little difficult to get out unless someone, sticks their arm down in there and helps you get out. And so I think I would emphasize the importance of relationships as a way of helping get out of those holes.
That's wonderful. From an anxiety/depression standpoint, how does a caregiver and or friend, right, additional support people, help someone who has developed the negative mindset to the point where you don't understand it, you don't know what you're talking about, until you deal with this, leave me alone?
Right. Well, it is, let's start with depression. So the sort of the painful irony of depression is the depression itself gets in the way of the things you need to do to get out of the depression. So, to have the motivation to exercise for 30 minutes each day, or to go outside for a walk, or to have that lunch date with a friend or whatever, those things are helpful. And that's the very thing that depression is getting in the way of. Or similarly with anxiety. So with anxiety, the sort of the strategies we use, like in therapy, are to face your fears, to be exposed to those fears, realize that the thing you're afraid of is probably not going to kill you or harm you. And in fact, you'll gain some mastery and confidence as you face those fears. But it's hard. If you, I'm reminded of a skit that was sort of can't remember what show it was on, but it was kind of a parody of the Newhart show. Newhart was a therapist played a therapist. He's a comedian who played a therapist. And so a woman comes to him with anxiety, a very specific fear. And he tells her that he's got the solution for her. And it's as simple as, and he yells at her to just stop it. If it was as simple as that, if we could just tell people, just stop being worried, then I'd be out of business and there really would be, no need to address mental health. But obviously it isn't like that. If we could just do that, it would be very, very straightforward. So I think ways friends, family can address this is start by validating, I appreciate that you're really scared right now, or that you've been really sad lately. That must be very painful. I went through something myself like that 10 years ago, whatever, something to sort of acknowledge that you hear, you see, that this person is suffering right now. And so that little bit of validation at least can be kind of a foot in the door then to some further discussion. Another approach that we take is to kind of put depression and anxiety and other mental health conditions in a similar level to other medical conditions. So like if I had abdominal pain chronically, I'd want to go get some help with that. Or if I had a chronic cough and shortness of breath, I would want to go get that addressed and figure out what's going on. And similarly, depression and anxiety, though there's certainly a lot psychological about them and a lot of social issues related to that, there are things that are also going on in the brain, and they're brain body conditions that we can help folks out. So that's a strategy that can sometimes be helpful to say, hey, you take meds for your high blood pressure and your diabetes, and you've done physical therapy for your chronic leg pain. Why not see a therapist for depression or start a medication for anxiety? So that, that can be another way of addressing those things.
That's really helpful.
Oh,
yeah.
I'm sorry.
And that's so helpful to give that sort of framework to think about it. It also, and forgive me for jumping in, it also, listening to you now, absolutely drives home the need for education. Mm-hmm. Somebody's got to help me understand that it's like a kaleidoscope. I can change it a little bit, have a different perspective on this,
sure,
and be more helpful, right?
Yeah. Absolutely. And I think the other thing for family members, friends who are worried about someone who might be depressed or anxious, you're not going to get it on the first try. It's not going to be like sort of this magical, you validate, you say, and then the person says, oh yeah, I should go see my doctor tomorrow about my depression. It will probably take multiple tries, and you may have to ultimately be a broken record about it. It's like, I know I brought this up 4 times already, but I'm really worried about you. And here's the phone number to so-and-so, could you please make this call? So I would counsel, it's easy to get discouraged if it doesn't work after several tries, but it may take several tries. It's a similar issue, actually. This is a common theme in people who have substance use disorders, like alcohol use disorder or other substance use disorders. It may take many tries before it sticks, before you get the person into treatment, and then you get a treatment that works.
That's phenomenal. So I'd like to, just speaking of the kaleidoscope, I'd like to shift gears just slightly.
Sure.
And ask you, Art, as a researcher and understanding the changes in the brain that manifest in dementia and Alzheimer's work, has there been anything in your research that has surprised you with regard to anxiety and depression and the changes in the brain?
Terrific question. Yeah, so I think, so first of all, people with dementia can certainly get depressed or anxious, and probably at a higher rate than older adults without dementia. And there's several reasons for that. There's sort of kind of the obvious thing, like especially if someone has awareness of dementia, like that's a pretty scary diagnosis and a depressing diagnosis. And so, like, just as a plain psychological reaction to some bad news, that would be understandable. At the same time, there's stuff going on in the brain, sort of the biology of the brain. And so there's a part of the brain called the hippocampus. Actually, we have 2 of them, one on each side. And the hippocampi have to do with not just memory. So they're sort of the classic part of the brain that is deteriorating in Alzheimer's disease, but they have to do with mood as well. So the hippocampus binds emotional information with memory. So like if you're trying to learn something and something dramatic happens, you're gonna know that a lot better because there was a bunch of emotion associated with that, as opposed to you're on hour 3 of reading some very boring book and you're not all that interested. You're not going to retain all that information all that well. And that's because the hippocampus is well, and there's an important reason for that. Like if you remembered everything, that wouldn't be very good. Emotion is a way of guiding where your attention should go. And so in Alzheimer's disease, when the hippocampus shrinks, it's not just affecting memory, it's affecting mood as well. It's affecting depression, it's affecting anxiety. So those things are at play with each other. So you've got the biological changes that are going on, and then you've got the psychological stuff. And you can help it at both of those levels. So there can be medications that can help sort of the more biological side, and then therapy and support and exercise and various other things that might help more at the psychological side.
That sounds really complicated. Again, from a research standpoint, right? How do you separate out what's causative, what's coincidental,
Yeah.
what's episodic, what's chronic. It's like, wow, I'm so glad there are people like you, not only studying it, but learning some really important things to help people like us get it.
Well, I would say I'm very pragmatic about this. I mean, to me, I'm not sure it really matters that it's that particular part of the brain that is not working right versus some particular stressor that's causing depression or anxiety. It turns out, like, so say for depression, meds and therapy are pretty much equivalent for it. There's some devil in the details kind of there, but pretty much equivalent. And then if you add the two, you actually get more benefit than either one alone. And honestly, it probably doesn't completely matter, like, how much of this is brain-based biological change versus stress. These systems interact with each other all the time. And, so medications can help rewire the brain. So can psychotherapy, it turns out. And so I'm pragmatic. Well, let's try stuff and just see. And if A doesn't work, we'll do B. And if B doesn't work, we'll try the combination of C and D, and, and so on. So honestly, I'm not sure it really matters a whole lot, just for like day-to-day care of people with depression or anxiety, kind of completely understanding how these things are linked together, because we've got a variety of effective interventions no matter what.
I have a very hopeful reaction to that, Art, as a caregiver, right?
Yeah.
Because oftentimes it's experimentation in a caregiving sense. Well, that didn't work. Let's try something else. Let's change the subject, right? One of the things that I learned, and we talk a lot about in our chats, is go to where the person with dementia or Alzheimer's is emotionally, intellectually. Don't ask them to come to where you are.
Mm-hmm.
And so talk a little bit, if you can, Art, about demeanor of a caregiver and an impact that would have on someone struggling with dementia or Alzheimer's.
It's a very insightful question. And I want to present this in a way that doesn't feel like it's blaming or stigmatizing caregivers. Because again, caregivers are doing the best they can. They're tired themselves. They may be depressed and anxious themselves, et cetera. There is some evidence to suggest that folks with dementia respond to facial expressions quite a bit. And of course we all do, everyone does. So, we're constantly reading each other's facial expressions and trying to understand what's the nonverbal stuff that's going on right now in our interaction. And people with dementia don't lose that. And in fact, because they may be losing other sources of information, perhaps because of hearing loss, or because they're not understanding, or because you're not remembering that you just told them the same thing a minute ago, they may even be more attuned and more reliant on, is this person angry at me? Do they love me? Why are they frustrated with me? Like, what is my caregiver, my loved one, trying to tell me right now? And so the advice that turns into, although again, this is not to blame caregivers or ask them to do the impossible, but trying to maintain some positivity in those interactions can be helpful. We mirror each other's emotions as well. That just happens naturally. I mean, you just watch, like, go to dinner and watch several people at a table together. In general, it's not one person crying, another laughing, another, paying attention to the ceiling. People are mirroring each other, and that's a unconscious thing that's happening all the time. And so that happens in the caregiver loved one relationship as well, that there's mirroring back and forth. And so if a caregiver approaches a situation with an angry face, guess what? that may not go so well, because the person with dementia may perceive that as a threat, or they may be sad, like, well, what did I do wrong here, et cetera. So again, it's tough advice, but to the extent that one can maintain a positive or even sort of constructive demeanor, it's like, oh, okay, I see that didn't go as planned. Let me try this other thing right now and see if that goes better. That might help situations out.
So two words that just popped into my brain as I'm listening to you. One is patience, right? God, please give me patience right now.
Mm.
And then the other is humor. Talk to
Mm.
us a little bit about appropriate humor, if there is such a thing, in a caregiving kind of situation.
Oh yeah, well, what a great question. I mean, humor serves such I'm not an expert on humor. I like humor. I like comedy. So I appreciate humor without having any expertise in humor whatsoever. But it's actually, I mean, it's another important part of the repertoire of human emotions. Being able to find joy or even sort of irony in a situation. So and it can be a way for people to connect. We don't tell ourselves jokes, we tell jokes to other people, right? So it's part of a relationship with other folks. So I think I don't know, I've been a little lost for words because it's such a great question, and it's not something I know like the research on beyond just my own personal experience with finding pleasure in humor and you trying to use humor to potentially diffuse a difficult situation. Humor actually can be a pretty good coping mechanism. So if you think about like avoidant versus more adaptive coping mechanisms, humor is can be, I'm embracing the absurdity of this situation right now. And, this stinks that we're in the situation, but I'm going for it. I appreciate, I may not like it, but this is kind of funny. This thing just happened, and let's go with it. So again, I'm being a little inarticulate about this because it's such a great question, and it's not a thing I think about a lot. But I think to the extent that one can maintain humor, and especially maybe tough, if someone is throwing a medication back at you that you're trying to give them, to find humor in that. But perhaps at other times, in a caregiver support group or with a friend or with another, a confidant or whatever, find that might be the time for some humor.
Yeah, I think the word that you used is one of my favorites, right? It's the absurdity of the situation, the complete lack of control of what's happening here. Right. Is kind of ironic, but what? Okay, can we chuckle about that a little bit?
Yeah, sure. Yeah.
General question, and we've talked about it sort of tangentially. Are caregivers, in your experience, more susceptible to anxiety and depression because of the situation that they are attempting to manage?
Absolutely. So about 1/3 of people who care for someone with dementia suffer from clinically significant depression or anxiety. So that's way higher than the background population, non-caregivers. So absolutely, they're higher risk. And, no wonder. It's A, stressful, B, chronically stressful, C, stressful in a way that interferes with one's own rhythms, whether it's sleep or exercise or relationships with others or whatever. So it, completely understandable that being a caregiver for someone with dementia may lead to clinically significant depression or anxiety.
Which becomes really important in terms of the self-care that you talked about, the social groups, the support groups, and all those kinds of things. The other thing that I consider, and it's, I hesitate to bring it up because it's kind of morbid, but it's kind of D on your list of things. We know the outcome, right? And the outcome is not anything any of us want. However, it is an inevitable conclusion of life. And so finding support for coming to grips with that, I think, would be pretty important.
What that triggers for me is grief, thinking about grief. So the classic grief is my loved one has died and I'm now grieving. However, as any dementia caregiver will know, it's more complicated than that. It's a multi-step while the person is still alive grieving process, because they're alive and they're not the same person in a lot of ways that they were 5 or 10 years ago. Especially, a loving relationship, whether it's spouse or partnered, you're also grieving the loss or the change of that relationship from partners to one person caring for the other. If it's an adult child, that's your parent, the person who raised you, and now you have a very different relationship with them. So you grieve that, if it's a friend, et cetera, et cetera, et cetera. So loss isn't just loss of because someone has died, it's loss because the relationship is different, because your activities are different. Your health is different as you're, a caregiver. So, a lot of the dementia caregivers I've worked with over the years, they've kind of taught me about this, that they've been grieving for the last 5 years, even as their loved one is still alive, because there are other things lost besides life.
And then add to that the relief when the loved one passes and the guilt you feel about that relief.
Yeah. Well, and I'm saying some general things about grief. I mean, people grieve in all different kinds of ways. There's no universal. I mean, grief is essentially universal of some sort, but like how people do it exactly varies dramatically from person to person, from culture to culture, from family to family. So there isn't necessarily like a right way to go about doing this, other than I would say acknowledging that grief is part of this process, especially if someone is feeling depressed. Some of that, depression and grief are very closely related to each other. And the grieving process looks a lot like depression. Some of those symptoms that I mentioned earlier for depression that come up in the questionnaire, there's a lot of overlap with grief. There are important differences, like grief is normal, but there are a lot of similarities in the symptoms.
I am thoroughly enjoying this chat and would love to, go for another however long. I'd like to open it up to anybody who's here who has a question or a comment for you specifically. And then I want to come back and ask one last question before we let you go.
Sure.
So anyone on the line here in the chat with us who would like to ask Art a question, share a story, perhaps a personal insight that you have, now's your chance. 3, 2, 1. Okay, then I'm going to just come right back to you, Art. What is your favorite? It's clear you love what you do, and it's been just really wonderful experiencing your energy and your knowledge and excitement about just the work that you do. What's your favorite encouragement to give to either Alzheimer's and dementia patients or the ones who are caring for them?
Well, thank you for that great question. And Susan, thanks again for this opportunity. It's just been delightful, and I very much appreciated your questions. And so I want to say this in a way that doesn't make me sound like I'm a Pollyanna or sugarcoating some bad news. But when people experience dementia, I mean, I think as any dementia caregiver will notice, it isn't like the light switch went off and all capabilities are gone. It's a gradual process. In general, there's variation, but in general, it's a gradual process. And some things go away at different rates than other things. Like I'm thinking about the mirroring of emotions thing. Like that sticks around for quite long. People can have very severe memory problems and still recognize emotions. They may not be able to like name them necessarily, but sort of feel those emotions and feel and sort of guess at what other people's emotions are. A lot of physical skills persist, related to walking and exercise and even musical skills and so on. Artistic skills. So there's really interesting literature about a very specific type of dementia called frontotemporal dementia that affects the frontal part of the brain and the temporal lobes where a lot of language centers are. And so people have language difficulties. They can also have problems related to behavior. They can get kind of impulsive. They can also look kind of depressed because the frontal lobes kind of help us with energy and motivation. But there's a really interesting series. There's a neurologist in San Francisco, Bruce Miller, who has studied artists who develop frontotemporal dementia. And it's not like their artistic abilities go away, they change. And, and art is a matter of taste. So I don't know if they change for the better or worse, but they're it's different. And it's not necessarily that the person enjoys it any less or is any less productive, but I encourage people to Google Bruce Miller dementia artist, and you will get to some of his stuff. And it's really quite fascinating. And so a lot of capabilities are still there. And even like learning is harder if you have Alzheimer's disease, but it's not impossible, especially in the early stages. It may take more repetition. So people can still, learn new things. So again, I hope I don't come across as sort of being absurdly optimistic, but I think that's where some of the hope can be there, that, yes, there's loss, and at the same time, they're retained abilities and maybe even some new abilities or capacities. Maybe someone's willing to try something out that they weren't willing to try out before. So that would be my little marker of hope in this conversation.
That's phenomenal. And then it triggers for me. It's like, okay, we got just a few minutes, but the episodic nature of change for many with Alzheimer's and dementia, they're fabulous one day. The next day, it's like, who is this person? What the heck? Mm-hmm. And just so I appreciate what you just said, Art, about discovery that is or can be perhaps a co-partner on the journey of loss.
That's a lovely way of putting it. Absolutely.
That's cool. I am so glad to know that you are out there doing the work you do. So truly honored to have you part now of this series. We have recorded this. You are recorded for posterity, which is fantastic. So I will be sending you a link once we have it posted. Share with your colleagues and patients and whomever. And just a reminder to everyone on this call and people who will find this later, SusanAMarshall.com is the website. There's a compassion chat button right at the top. There's an archive there. It goes back to March of 2021. So go find the people. Art, I have to tell you, you are one of the most energetic and engaging guests that we have had over the series of this couple of years. And again, I thank you so sincerely for sharing your time, your energy, and your knowledge with us. Appreciate you.
Thank you, Susan. And I also want to acknowledge my many, 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 many colleagues in this space. So there are a lot of people locally, regionally, nationally, internationally, who are just as compassionate or just as passionate and hopefully compassionate as I am in this topic. So it takes a huge effort to do research in Alzheimer's disease and to do clinical care and educate others. So I feel very fortunate that I've got such wonderful colleagues at UW and elsewhere who do this work. And I'll put one final plug in. If folks are interested in participating in research, please look up feel free to contact me or contact Susan to contact me. But look up either the Wisconsin Alzheimer's Institute or the Wisconsin Alzheimer's Disease Research Center. So both of those sites are sites of research studies. And our hope is that we can discover both a cure for Alzheimer's disease and other effective treatments for it and for caregivers of people with dementia as well.
That's fantastic. One last question. I got to apologize for it, but you grew up in Chicago. Are you a Bears fan?
Yes, I'm a Bears fan, but I've lived here for 20 years, so I'm a Vikings fan as well. I mean, oh my goodness, what a terrible Freudian slip. I can't believe I said that. I'm definitely not a Vikings fan, but wow. Well, hopefully you can edit that out and dub in Packers.
Yeah, Josh.
Wow.
Cancel that one.
Oh, that's awful. I'm going to lose my Wisconsin residency over this.
No. You're part of the family.
I'm a big and I'll say a Badger fan as well. So
there you go. Well,
being part of the university for 20 years.
I think that's probably something that's really very wise and fun. Yeah. Art, you are a blessing to so many. Thank you so much for joining us. Thanks to the rest of you for being with us tonight. We will see you again next month. Take care all. Bye-bye.